Good morning, everyone. I hope you're enjoying the summit. Now we're going to talk to you about a rare disease that's a form of kidney disease in the African American community. It is FSGS. Before we take a deep dive into kidney disease and FSGS, let's look at the statistics and see why it's so relevant for our audience today. While African Americans make up about 13% of the population, they account for 35% of people with kidney failure in the United States. Diabetes and high blood pressure are the leading causes of kidney failure among African Americans. FSGS is a rare kidney condition that is the leading cause of nephrotic syndrome, which is a kidney disorder. In adults about 45 years or older, FSGS occurs more commonly in African Americans than in Caucasians, and the rate of decline of kidney function is generally more rapid in African Americans. Black Health Matters has partnered with Retrophin to help educate African Americans about kidney disease and FSGS. After you hear from our esteemed physician presenter, Dr. Kirk Campbell, please go to the Retrophin exhibit hall, the exhibit hall where Retrophin is, and get more information on FSGS and learn if a clinical trial is could be an option for you. Now I'd like to introduce you to our presenter. Dr. Kirk Campbell is an associate professor in the Division of Nephrology at the Icahn School of Medicine at Mount Sinai. And now we'll introduce you to Dr. Kirk Campbell, who will take us through kidney disease, FSGS, and what we can look for in terms of advances in treating this disease. Hello, Dr. Campbell.
Hello, Rosalind. Thank you. Thank you so much for the introduction and for the organizers for inviting me here today to talk about FSGS and rare kidney disease. I'll share my screen. Okay, so the title of the talk will be Chronic and Rare Kidney Disease in African Americans, what everyone should know. So the kidneys, just from a very basic perspective, are found in the back on either side of the spine, and they have a number of interesting functions in the human body, including regulating blood pressure, removing waste and water. They produce a hormone that will promote red blood cell production, and they help to regulate growth in children. The kidneys really also filter between 120 and 150 liters of blood per day. But of course, we only make about a liter or two of urine. So they can filter out a lot of waste while retaining a lot of important metabolic products essential to normal human physiology. You know, chronic kidney disease is a very important topic for African Americans, right? And chronic kidney disease is a general term that we give to individuals who no longer have the ability to fully filter toxins and waste from the blood, and thereby having a diminished performance of full capacity. There are 37 million individuals in the US with kidney disease, but if diagnosed early, it can be slowed or even stopped. And just to put this in perspective, as Rosalind mentioned during the introduction, even though African Americans make up 13% of the US population, they account for 32% of patients with kidney disease in the US, really 4 times more likely to develop kidney failure than Caucasians. And, you know, one type of kidney disease is nephrotic syndrome, and it's an area of significant interest for me personally and for a lot of my colleagues. This is the type of kidney disease that's really characterized by a lot of protein being spilled in the urine. There are many different causes, and actually, overall, diabetes itself is one of the main causes of nephrotic syndrome. There are blood tests and a kidney biopsy that's really essential to identifying the underlying cause. And one of the main causes is FSGS, what we refer to as focal segmental glomerulosclerosis. And as we'll discuss in subsequent slides, this rare kidney disease is actually quite prevalent in African Americans. So, what is FSGS, right? It's focal because not all the filtering units of the kidney are affected. And it's called segmental because of the ones that are affected, it's a part of them that actually gets scarred. So, it's really a patchy scarring of the kidneys that we see under a kidney biopsy. And the other terms in the name, glomerulosclerosis, really refer to the filtering units and the scarring that happens over time. So overall, FSGS is really a disorder that affects the kidney's filtering units, and they stop the blood from being properly filtered and thereby causing protein to be spilled in the urine. And patients, again, of African descent, especially those from Western Africa and Caribbean descent, are disproportionately affected by FSGS. And this is kind of what happens at the structural level. So this is a sort of overview of what the kidney would look like in cross section. And when we get to a more microscopic level, we can actually decipher some of the cells that make up the filtering unit, right? And in particular, the cells on the top of this image called podocytes, these are thought to be quite essential in maintaining the filtering capacity of the blood and keeping protein from spilling in the urine. And there's intense interest in understanding the function of these cells. And we know that a lot of gene defects that cause FSGS originate from mutations to genes that encode important podocyte proteins. So when the podocytes become damaged, uh, again, you see a lot of protein being spilled in addition to other molecules into the urine. So in this image, on this side, you see blood, and on the left, healthy podocytes and everything that's essential to being kept in the circulation. White blood cells, red blood cells, protein, they're kept where they should be. And you see podocytes on the other side lining the urinary space. But during injury, when these podocytes become injured, you do have a disruption of normal filtering capacity and you have spilling of these components in the urine. And so, importantly, physicians would do a urine study to detect proteins and other related molecules that shouldn't really be there. And looking at a cross section histologically, this is what the normal filtering unit of the kidney would look like, where blood would essentially come in to this filtering unit and get returned to the circulation, essential metabolites, while urine would pass to the proximal tubule and becoming the primary urinary filtrate. But when you have the scarring, again, a disruption with ultimately a decreased urinary output, impairment in normal kidney function, and a lot of spilling of protein and other molecules that can be detected clinically. So, what are the symptoms of FSGS? One of the first signs that patients will mention to their physicians is foamy urine, right? This is actually one of the hallmarks of a large quantity of protein being spilled in the urine. But patients can also have an elevated blood pressure. They can notice some retention of fluid, what we refer to as edema. And this can happen around the eyes, around the feet, the abdomen. And they can also have a high cholesterol or a low albumin. And these actually, the constellation of findings here are what constitute what we call the nephrotic syndrome, right? Which is something that has to be treated very carefully in the clinical setting. FSGS really has to be diagnosed by a kidney biopsy, and that's the definitive way that physicians will look under the microscope to detect the injury pattern that's classic and the extent of the injury. But also, that's complemented by blood and urine tests, which help clinicians to understand how well the kidneys are working and how much protein is being spilled in the urine. But a biopsy, which I think this has been decades now that we've advanced the way the technique is performed, is an essential part of the toolkit for making the right diagnosis. And it actually, FSGS has increased in prevalence over the last few decades for unclear reasons. And it really is now the most common cause of end-stage kidney disease in the US. So patients who require dialysis, the most common primary glomerular disease is FSGS. There are other types of disorders of the filtering units, but this is the most common primary one. Overall, diabetes is the most common cause, but of the primary glomerular causes, FSGS is number one. So it accounts for about 20% of the nephrotic syndrome diagnoses in children and 40% in adults. Um, and globally, it affects 8 in a million adults and 1 in a million children per year. And as we mentioned, it is more common in individuals of African ancestry. And the sporting world has certainly been impacted by the high prevalence of FSGS with basketball players Alonzo Mourning, Sean Elliott, two individuals who have had FSGS and have actually gotten kidney transplants as a result of progressive decline in kidney function. There are different types of FSGS. I mean, so when a biopsy is done, that really just describes the pattern of injury. It doesn't really tell you if it's genetic versus linked to cancer or medication or viral infections. In fact, during the recent COVID pandemic, we're seeing some patients developing FSGS as a result of coronavirus infection, patients who didn't previously have kidney disease. So there's a lot we need to learn about it, but there is a primary idiopathic form, and there are certainly genetic and other etiologies that we need to be aware of. And just on the topic of genetics, there is a gene called APOL1 encoding an apolipoprotein L1 protein. And these gene mutations are highly prevalent in individuals who develop kidney disease. In fact, they account for 70% of the non-diabetic kidney disease in African Americans, and about 4 in 10 African Americans on dialysis actually have gene mutations in APOL1. And so there's a lot of intense research happening trying to understand how these gene mutations actually cause kidney disease. And just an overall summary, interestingly, and I know that there was a talk on sickle cell just before this, but like in sickle cell, where the sickle trait may be protective against malaria, it turns out that in West Africa, which is thought to be sort of where these mutations are more prevalent, carrying a mutation to APOL1 is protective against trypanosome infection, which causes African sleeping sickness. So carrying this mutation protects against one disease, which is infectious, and ends up increasing the risk for developing chronic kidney disease and non-diabetic related kidney disease. So having two high-risk variants really confers a significant risk for developing progressive kidney disease. Having one may have sort of an intermediate effect, which we'll discuss in another slide. So Girish Nadkarni and colleagues here at Sinai actually showed that having these mutations in the APOL1 gene will increase the risk of having hypertension and elevated blood pressure. You can actually see sort of a dose-dependent increase, if you will, in the blood pressure at a young age in individuals who may have 1 versus 2 copies of these APOL1 disease-causing variant. So, again, a lot of work ongoing here, but in the future, we can assume that genetic testing will become a very important part of the clinical interactions that we have with patients in the kidney space. So, let's switch to how FSGS is treated. Unfortunately, there are no medications that are approved by the FDA specifically to treat FSGS. So we typically use a combination of lifestyle changes as well as medications that are repurposed from other etiologies, right? So blood pressure medications like ACE inhibitors, angiotensin receptor blockers. Sometimes we'll use steroids like prednisone or the immunosuppressive agents that were not specifically designed to treat FSGS, right? So this, of course, can increase the number of side effects that patients may have, and also limits really the efficacy and effectiveness of the medications that we prescribe. So there is definitely an unmet clinical need for more effective targeted treatment for this disease. So, I'd just like to sum up by really introducing and highlighting this shared decision-making process that's quite important for patients to have. I mean, a good partnership with your doctor can help working towards joint treatment goals. Really understanding the diagnosis, the lab reports, crucially important, exploring all the medication and treatment options. I think that not all clinical sites have robust clinical trials operations. And so looking for clinical trial opportunities, crucially important, understanding the side effect profile of medications that you take, proper nutrition, exercise, utilizing online resources, very important. For FSGS nephrotic syndrome, diet, exercise, real basic things that we recommend for heart health, crucially important here as well. So very important for patients to really take, the treatment goals and options into their own hands. And these are just some additional resources that are available. NephCure, the NephCure Foundation, Black Health Matters, the National Kidney Foundation site, and the American Association for Kidney Patients are some exceptional resources where individuals can learn more about the options that are available. So I think I'll pause there and answer any questions. And I know that there are some questions in the chat. So the first question is, will drinking a lot of water affect or increase chronic kidney disease? And that's a good question. We generally recommend avoiding volume depletion or dehydration, if you will, um, for overall kidney protection, right? One of the types of acute kidney injury can develop when individuals have lost volume from a lot of vomiting or GI sources, otherwise, or significant bleeding, for example, that actually can cause kidney injury. So we recommend hydration. That's important. But of course, if individuals have decreased kidney function or if they have heart disease, then you want to be cautious about the fluid intake. So I think it really depends on the individual, but as a good rule of thumb, we encourage significant fluid intake. And again, one type of overall kidney disease is related to having kidney stones, and there it's crucially important to have a significant fluid intake. Thank you for that question. The second question is kidney disease the result of UTIs? And urinary tract infections certainly in the most severe form can impact kidney function through a variety of ways. I mean, there are individuals who have had really an ascending infection where the kidney itself becomes severely infected, and there are patients with polycystic kidney disease, for example, where the cysts themselves can get infected. It's also very difficult to treat. So, chronic urinary tract infections, your recurrent ones, not the once in a while setting where it gets better quickly with a day or two of antibiotics, but individuals, some people have indwelling catheters. So in the more severe form, absolutely over time, you can have an impact on overall kidney function. Another question: what damages the podocytes? That's very interesting, and there are a number of things, and we sort of touched on a few of these in one of the slides. There can be genetic causes where the cells themselves get injured through various signaling pathways. There's a hemodynamic insult with hypertension, for example, that can happen. They can be infectious etiologies. HIV can infect podocytes. As I mentioned in the talk, there's some evidence that coronavirus maybe indirectly can cause podocyte injury. So this is something we're trying to understand, because obviously targeting podocytes is one way that we can possibly slow the progression of kidney disease. And of course, the study we mentioned, sparsentan, is targeting receptors on the podocytes, right? That we know are important for protection. So, I think this is an area of intense interest that's being advanced. The next question is, are you finding much success with engaging African American patients in research as well as clinical trials? And I think, that's a great question, and certainly a bit of a mixed bag. I think we can always do better. I think when we're discussing kidney disease, FSGS, as we mentioned, disproportionately African Americans are affected. So we absolutely want to see more engagement And I think there have been, I think now, rightfully so, a lot more attention being paid to more proactively engaging African American communities in the clinical trials mission, and really making sure that folks understand that this is for the benefit of their own health, and really not necessarily just an altruistic mission of advancing science in the abstract form to benefit others, but it's become now one of the ways that we can actually get better treatment for rare disease, right? As we mentioned, there's no treatment available for some of these disorders. So the trial is almost the only option for bringing some of these disorders into remission. So another question, good morning. This session highly echoes the following webinar on July 15 by Harvard Medical School on the impact of race, racism, biology, and social determinants of health on kidney disease disparities. Absolutely. I think the social determinants play a significant role, right? There are possibly genetic factors that increase the risk of developing certain diseases, but that's not the full story, right? Access to healthy foods and being able to find the time to exercise, and I think all the other factors that come into play really impact overall health and kidney disease in particular. Next question: how has the COVID-19 pandemic impacted enrollment in the clinical trial? Well, I think different parts of the world and the country as well were impacted in different ways at different times, and so it's sort of been kind of a challenging process to first ensure that the patients who've been enrolled continue to receive their study drug and optimal care. I think at many sites that were hard hit, including ours, recruitment and on-site activities were paused during the peak of the pandemic, but we've since reopened, and hopefully, as again, at least at the local level, where the prevalence and new cases of COVID remain at a lower level, we can continue to safely recruit, enroll, retain, and treat patients. So it really depends on the local geographic realities at the time. Is there a test that doctors can run to see if I have FSGS? That's the next question, and also a great question. I think that there probably the closest thing would be a genetic test. If a patient has a known disease-causing mutation and they have all the signs of FSGS, including spilling a lot of protein in the urine and so on, it's quite likely that that's the etiology, right? And I think in the pediatric population, the kidney biopsy may be done a little bit later, right? Oftentimes the pediatricians will choose to try treating the disease or doing genetic testing even before the biopsy. So the biopsy is, of course, a little bit harder to perform in children. But I think ultimately in adults, the kidney biopsy is important for many reasons. Not just because someone has FSGS doesn't mean that there's no other underlying disorder, right? We've diagnosed FSGS in patients with underlying diabetes. We've diagnosed various kidney disorders in patients who have underlying myeloma, and we're seeing the myeloma cast deposited in the kidney, for example. So we can pick up a lot by doing the biopsy, and we still encourage that to be done. Next question: is a plant-based diet good for someone with FSGS and currently on dialysis? That's actually an area of intense study at this point. I think patients on dialysis do have different metabolic needs than patients with chronic kidney disease. And it also depends on how much residual kidney function the patient on dialysis has. We want to maintain the residual function. If somebody's still making a significant amount of urine, you want to do whatever you can to support that. So, I think there are firm believers in the plant-based diet. We have certain recommendations for protein intake, which is sort of like a gram per kilogram per day, and we 1 milligram per kg per day. I'm sorry, and I think we sort of encourage this overall, and plant sources may be healthier, and that may be reasonable. What recourse can we take if we've already started dialysis to turn the disease around? And of course, patients who are on dialysis, I think at that point, recovery of kidney function is unlikely, and you know, um, uh, transplantation is likely the best option. And what one would hope that dialysis is viewed as a bridge to transplant, right? And in the best sense, that's the goal. There are some patients with a severe acute kidney injury ending up on dialysis who can have a recovery of function, but that's usually not the progressive sort of diabetic or focal sclerosis that we're discussing here today. Uh, what actually causes protein in the urine? Well, the protein in the urine is actually caused from what's being spilled right from the blood. So there is protein in the blood, and it's albumin, right? And it's not normally spilling into the urine because the filtering capacity to retain albumin in the blood is intact. So when there's injury to the kidneys, that's when the protein spills. And the one that we mention a lot is albumin, but there are other proteins that also spill there of smaller size, for example. The next question is it possible to chronically have low levels of protein in the urine without having kidney disease, no diabetes, controlled blood pressure? So I think maybe the question referred to having higher levels of protein without having kidney disease, because having low levels of protein is normal, right? So I'll sort of turn the question around a little bit and say, um, it's interesting. There is some evidence that there are patients who may have protein in the urine, um, certainly at a low level, and really have no identifiable kidney disease. I think depending on the level of protein in the urine, we may still want to do a kidney biopsy to rule out any clear, histologic changes that could account for this. But from a signaling perspective, it is possible, especially for some of the smaller size proteins, to end up in the urine, maybe from charge defects or so on, without actually having disease. The question of mentioned controlled blood pressure, and actually having high blood pressure can cause low levels of protein in the urine, right? Um, you know, uh, Individuals with hypertension can have what we mentioned as called subnephrotic proteinuria, and that's actually quite common. So it's possible that over time, even though the blood pressure is well controlled, the low levels can persist. Another question: are there treatments being developed for the genetic APOL1 forms of FSGS? And that's a great question. Yes, there are, and there are companies targeting APOL1 therapeutically, while the research is ongoing to try to more fully understand how APOL1 actually causes kidney disease. Next question: how does diabetes cause kidney failure? And diabetes is actually, as we mentioned, the most common reason that patients develop kidney failure. Um, and it actually causes a multitude of effects we think related to actually the high glucose level, causing the release of reactive oxygen species and other things that can actually directly injure cells in the kidneys and the blood vessels, right? We know, for example, how diabetes can affect vision, right? And diabetic retinopathy and eye disease. Well, there are small blood vessels in the kidney as well, right? And they also get impacted in the same way. In fact, the eye manifestations and the kidney manifestations seem to go hand in hand in patients. Uh, are there certain professions can induce the disease? I guess maybe the question pertains. I'm guessing where certain um, uh, jobs or activities from work that can possibly bring about the disease, and I think there's some evidence now that there are environmental factors that can interact with genetic predisposition, and APOL1 is one story, for example, where we don't know that having the genetic predisposition with APOL1 is enough. There was an interesting recent manuscript showing that air pollution and being in a polluted environment can actually be additive and increase the risk for kidney disease in patients. how does the diet affect individuals having kidney disease? That's also, as we mentioned, the plant-based diet study. That this is again a very interesting area of research. What we do know is that a high salt diet can actually make it a little bit more difficult for some of the blood pressure medications to work, and some of the medications that might protect from kidney disease. So there seems to be some interaction between sodium, high salt versus low salt diet, and outcomes. And so we often counsel our patients to have a low salt diet, and the other lifestyle activities like exercise and weight loss can also have a significant impact. But having a balanced diet is crucially important. I think probably take one more question. Why is there a difference between EGFR for African Americans? And this is an area of intense conversation right now. I think the American Society of Nephrology and the National Kidney Foundation, they've set up a task force to really look at the variability in estimated GFR, that's the glomerular filtration rate for African Americans, and the proper use of these race-based correction formulas, which I think are suboptimal to begin with, and I think there's a lot of speculation about the variability, but I think it's not well understood, and certainly an area for intense study. So I think I will pause there, and I just want to again thank the organizers for inviting me, and thank everyone for the great participation and questions. And as Rosalind mentioned, feel free to stop by the booth that Rich Ruffin has sponsored. I'll be stopping by there as well to answer questions on FSGS as well. Thank you.